I'm Susan Dubois. I'm an endocrinologist and I work for community care health centers and I support this work. Mary and I have been working together for about 10 years now, working with the Texas Stride family. So I'm glad to be here today.
So we hear a lot about insulin. What is insulin? And what does it do in the body?
Insulin is a hormone, which means it's a chemical transmitter. It is released by the islets of Langerhans, which are or the beta cells of the pancreas. So they produce it, it goes into the bloodstream, and it travels throughout the body to help open the door for blood sugar to enter into our body tissues and nourish us. So when insulin is working appropriately, glucose, so you will eat a meal, and as your blood sugar starts to rise, insulin levels will match the rise in blood sugar and allow that glucose, which is our body's fuel, to get into the places where we need it, into our brain so we can think, into our lungs so we can breathe, into our heart so they can beat everything we need to do.
Right. Regarding insulin, you have type 1 and type 2 diabetics. What's the difference between type 1 and type 2 diabetes?
That's so important to know. So insulin, and I think it illustrates the point that insulin is life-saving. Insulin is not bad. And in fact, before 1917, I believe, or 21, one of those years, insulin was discovered. And prior to that, all people with type 1 diabetes would die because you need insulin to live. And so insulin is life-saving. However, insulin resistance is bad. And what we know is that when our bodies become resistant to insulin and it takes more and more insulin to do the job, we have associated diseases like hypertension and heart disease and liver disease and so forth, chronic kidney disease. So we want the right amount of insulin to do the job without having that insulin resistance. So type 1 diabetics have an autoimmune disease that attacks the beta cells so they don't produce any insulin. And type 2 patients produce insulin. In fact, they produce more and more and more insulin because they become resistant until the time when their pancreas starts to wear out and produce less and less over time.
So how do people become insulin resistant?
That is $1 million question. Diabetes is most of the time a polygenic disease, the word poly meaning many. So there are many different genetic defects that work together to cause someone to be at risk for type 2 diabetes. And that is why it's been so hard to find a cure, because we would have to fix every single defect, and the defect from patient to patient, or the differences, may be, many. And to address this problem, we've come up with multiple different medications that target different organs of the body. So we have metformin that targets the liver. We have sulfonylureas that target the pancreas. We have drugs that mimic intestinal hormones, GLP-1 and GIP. And so we have other drugs that really are sensitizers at the muscle and fat cell. So we have many drugs to address this problem.
Right. So there's slow acting and fast acting insulin, right? So what's the difference between the two, and why would you prescribe one over the other?
We need, when our bodies function the way they're supposed to, our bodies make a little bit of insulin when we're not eating. We call that the background or basal insulin level. So it's like a blanket that just sort of covers our needs to move a little bit of sugar around while we are not eating. When we take in energy, when we have a meal, and in particular when we have a high carbohydrate meal, we're taking lots of energy in all at once. And then we need a burst of insulin to cover that and move it quickly into the liver and get it out of the bloodstream. And so we call that type of insulin a bolus or a rapid acting insulin. So when our bodies function the way they're supposed to, the pancreas does that. It's got this little bit of insulin, and then you eat a meal and you get this burst, and then it goes back down again, and maybe you eat a smaller meal, you have a little burst, and so forth. When we have a patient who is advanced in their diabetes and their pancreas can no longer produce insulin, in the beginning, often we can just give a basal insulin and just boost them up 24 hours a day, and their medications, their oral medications, can work with their own pancreas to get over the meal time. But in far advanced stages, they need both types. So usually we introduce that basal insulin first, and then if they are spiking after a meal, the sugar's going, well over 180, 2 hours after a meal, then we're going to start adding mealtime insulin. But that becomes really complicated because when your own pancreas works, it'll produce a little bit of insulin with a small meal and a big insulin with a bigger meal, and it matches beautifully. It knows what it's supposed to do because you have glucose sensors and receptors in your body, and it's like this orchestra. But when the doctor is doing it or you're doing it for you, it's hard to know how much insulin does a burrito need versus a salad with croutons. Those are two very different meals. So you've got to learn how to match it. And patients who grow up with diabetes from when they were small, they learn how to count carbohydrates in grams, and we'll give them a carbohydrate ratio. So they'll base their mealtime insulin based on the carbs divided by that ratio as units of insulin. It's harder for older folks who get it later in life to learn those skills, but they certainly can, and we try and teach them.
Right. Okay. Thank you.